to open up hospitals to address the problem. So they're part doctors, part entrepreneurs, part philanthropists, if you will. They may not be as famous as some of India's software or IT entrepreneurs, but in many ways their contribution is every bit as significant. So the ophthalmologist opened an eye hospital, the oncologist opened a cancer hospital, the cardiologist opened a heart hospital, and so on. And over time, some of these have evolved into multi-specialty hospitals that also provide services for people with kidney disease, or people who need hip or knee replacement, and in some cases even very advanced procedures such as organ transplants. The important thing is that they're all private hospitals, and even the two that are not-for-profit private hospitals are run in an efficient and business-like way. Some of them are listed on the stock market. Some of them have private equity investors. All the same, the goal of the founders and the goal of these hospitals has been to provide high-quality care at ultra-low cost to as many people as possible in a financially viable way so that the business model can be sustained and scaled over a period of time. As one of the doctors told us, charity is not scalable. So in order to expand and extend their services to more people, they've had to be financially viable. Now, what you see in this slide are the prices charged by these hospitals for various services. And if you look at the figures in red, it shows you the India price compared to the US price. And you'll find that the prices range from anywhere from 1% to 15% of US prices. To put it differently, it costs 85% to 99% less to have these services provided in Indian hospitals, such as the ones that we looked at. Now, even at these very low prices, these procedures are quite expensive for the average Indian consumer who makes maybe $1,500 a year. And therefore, the pressure is on these hospitals to continue to innovate. And so this is not a process that is over, it's an ongoing process. And the interesting thing is that despite these low prices, these hospitals are quite profitable. Now, you might ask if these hospitals are as cheap as they are, is that because their quality is poor? We've already indicated that their quality is pretty good, but let me just add here that if you look at the outcomes of the medical procedures in these hospitals, you will find that they compare favorably with U.S. hospitals. And I'm thinking of standard metrics such as the complication rates from surgery, infection rates after surgery, survival rates, and things of that sort. You see here the example of two hospitals where the outcomes are shown for the Indian hospitals along with the average for the U.S. hospitals. And the conclusion is that sometimes the Indian hospital is a little better than the average U.S. hospital, and in other cases it's the other way around. Now, we should point out that these hospitals are not representative of everything that goes on in India. Not all Indian hospitals are providing quality care at these such low prices, but our exemplar hospitals are doing so, and in the process they're showing that it is possible to provide quite high quality care at rather low prices. And even poor patients who may not even be paying for their services are provided care at about the same level as the more affluent patients. So there are differences in the quality of non-medical services provided to the affluent compared to the poor, but in the most important aspects of medical care, there is no difference. You might also wonder if the lower cost of Indian hospitals is somehow the result of low salaries in India, and there is some truth to that. Indian salaries are significantly lower for many categories of workers. They are much lower for nurses and administrators compared to U.S. salaries. For doctors, the gap is not as big, but it is still a significant gap, as you can see from the slide. So we asked ourselves the question, what would happen if these Indian hospitals paid their employees the same rates that U.S. hospitals pay. And in this graphic, what you see is the result of that analysis. This is a heart hospital that normally provides open heart surgery for about $3,160. And this is the price charged to paying patients who pay full price. If this hospital paid all its employees U.S. level of salaries, the cost of the hospital would go up to $13,700, which is still less than one-fifth of the lowest price you could find in a hospital, for instance, in Texas. So there is still a very large gap, and we cannot explain the entire difference simply based on low salaries. In fact, you could argue that some costs are actually higher in India than they are in the U.S. Cost of capital is usually significantly higher. Urban land is more expensive. Equipment and devices that are imported usually cost more in India than they do in the U.S. So there is something more to this story. The question is, what is it? If it's not low salaries, if it's not low quality, what is it that allows these hospitals to be so efficient? And the answer, we think, is the way they are organized and the three advantages that they have developed. One is a hub and spoke network. Second is task shifting, which is a familiar concept, but one that these hospitals have taken to new heights. And the third aspect is old-fashioned frugality in everything they do, but applied very creatively across every aspect of their operations. Tying the whole thing together is the purpose of these enterprises, which is to provide quality care to as many people as possible, both rich and poor. And the interesting thing here is that by trying to serve both the rich and the poor, these hospitals are forced to pursue both high quality and ultra low cost at the same time. Rich patients provide revenues for these hospitals, and they force the organizations to deliver high quality services because these patients would simply go elsewhere. They might even go overseas because they can afford to if service is not, or the actual medical care is not up to global standards. The poor, on the other hand, need costs to be extremely low, and they contribute to this whole model by contributing volume and contributing the experience of the doctors, which allows them to improve quality over time for everybody. So that's the basic business model these hospitals are using. Now we'll say a little bit more about each aspect of this design, and that starting with this idea of the hub and spoke. It's really a simple idea. The idea is that in the hub, you house the most expensive equipment and the most skilled doctors. And in the centers of excellence, which are really super hubs, if you will, you may even have a large training or research function. In fact, 6 out of the 9 hospitals are extensively involved in training doctors and even conducting applied research. At the spokes, on the other hand, you do diagnosis, basic diagnosis, routine treatment, follow-up care for patients after the diagnosis may have been done with the help of doctors in the hub. And there is then a connection, a telecommunication link, if you will, between the spoke and the hub. And the important thing here is that the spokes are gateways to the hub. They are not mini hubs. So you don't duplicate the equipment that you have in the hubs in every spoke. Now, to illustrate this with the example of one hospital, take the case of L.V. Prasad Eye Institute. If you look carefully in this map, they are pretty extensively involved in the state of Andhra Pradesh. They have 3 tertiary care centers across the state. They have 1 center of excellence in the city of Hyderabad, where the hospital was founded. They have 20 secondary care centers, and they have 94 primary care centers connected through a layered system of hubs and spokes. The idea is that a person living in a small town could go to a typical vision center or a primary care center, which would be a place that looks something like this. They would walk in, and there's only one appliance there, one instrument really, that is used to check the eye. And based on that, person may, if they need glasses, will be provided glasses on the spot. They carry standard stock of prescription lenses, and if the person cannot afford to pay, they will provide it for free. There's no charge to the patient to walk in and avail of the service. If the person needs something more advanced or has a more complicated problem, they would be referred by the staff here to a typical secondary center, which would be a little farther away. And in the secondary center, they could actually perform cataract surgery. They are staffed with rotating ophthalmologists who come from the hubs. They may have an optometrist as well. And for people with even more complicated problems, they would get referred to a tertiary care center or a center of excellence in Hyderabad, where the most advanced procedures can be carried out. And where, as I said before, there may be education and training functions as well being performed by the doctors in this at these centers. It's an interesting tidbit that two of the high hospitals that we have included in our study probably account for 25% of all the ophthalmologists working in India. In other words, they have trained a lot of people for the entire country, not just for their own network. Another example of similar structure is HCG Oncology, which is South Asia's largest cancer network. You can see it has 4 hubs in 4 big cities, including a super hub, if you will, or a center of excellence in Bangalore, where the hospital was first started. It has 17 spokes all over the country. And in a similar manner to the eye hospital chain, when you go to the hub, you would see the most sophisticated equipment, such as a PET CT scanner. You might even see a cyclotron in some of them. And in the super hub, or the center of excellence in Bangalore, you would see the CyberKnife, which is a very expensive piece of equipment. So for advanced procedures, advanced diagnostics, patients would go to the hub, where some of the best oncologists and doctors are stationed, and others would go to the spokes, where they would get either initial diagnosis or get referred to the hub for further consultations. Now, the telecommunication link between the two sites, the hub and the spoke, allows someone like this lady, who is a medical physicist, to design radiation treatments for patients in the spokes. Medical physicists are in short supply in India, and you couldn't have one at each spoke, so they're concentrated in the central location, and they can remotely look at the condition of the patient, recommend treatments, which are then administered at the spokes by radiation oncologists and other doctors. So the interesting thing about this arrangement of the hub and the spoke is that the hub and spoke system obviously lowers cost. And it lowers costs because it allows the hubs to achieve high volumes and become focused factories at what they do. Just to give you an example, Narayana Health performs more open heart surgeries than any other hospital in the world. Similarly, Arvind Eye Care System performs more eye surgeries than any other hospital in the world. So by creating this kind of volume, it allows them to achieve high productivity among doctors and with all of the equipment involved. To give the example of the eye hospital again, an average surgeon in that hospital might perform between 1,000 to 1,400 operations a year, compared to the standard of maybe 400 in the United States. Similarly, in terms of open heart surgery, doctors at Narayana Health might perform 400 to 600 open heart surgeries a year, compared to 100 to 200 in the U.S. So the hub and spoke system allows the doctors and the equipment to be utilized very efficiently. The equipment is used efficiently because they run the equipment 24/7. And because of the high volumes, they can keep using the equipment almost all day long. For instance, an MRI machine, which might be used 4 or 5 times a day in a leading hospital in the U.S., might be used 15 or 20 times a day in these Indian hospitals, including at night, when some hospitals provide discounted prices to encourage patients to use the facilities during off-peak hours. One of the doctors we met put it nicely. He said, "You've got to make the equipment sweat." And by golly, these hospitals really do make their equipment sweat. The hub and spoke system also allows for economies of scale in purchasing medicines and supply and equipment and so on. Now, what's interesting is that this system also improves quality. This is an important part of explaining why these hospitals are able to simultaneously achieve low cost and high quality. It helps to improve quality because when doctors perform the same procedure over and over again, they get to be better at it. And doctors know that if they go to these hospitals, they will get more training and more practice, and they'll become better doctors. So these hospitals are able to attract some of the best doctors to work for them. And because they have their own training programs, they're also able to pick and choose the best of the crop to engage in their own hospitals. The other thing that these hospitals are able to do to improve quality is to constantly update their protocols and develop protocols for more and more procedures, at the same time constantly update them based on experience and practice. One of the doctors at the Care Hospital, Dr. Reddy, who is one of the founders, believes that any elective procedure can be subjected to rigorous protocols that can both help improve quality and reduce costs. And he gives the example, their own experience with angioplasties, where the norm internationally is that if you do 200 angioplasties, probably one of those patients is going to require emergency surgery. And for every 2 patients that requires emergency surgery, one is probably going to succumb on the operating table. At Care Hospital, on the other hand, they've done 40,000 angioplasties, and they've only had 2 patients who have required emergency surgery, and only one has succumbed in all these years. So it goes to show that these protocols can actually help improve quality as well. The third way in which the hub and spoke design helps improve quality is to promote innovations. When a hospital or a doctor performs same procedure many times, they begin to look for ways to improve the procedures. And so Indian hospitals have actually contributed to some medical innovations, like the ones shown on the slide. I don't want to get into each one of them in detail, but in the case of open heart surgery, Indian hospitals have pioneered the system known as the beating heart surgery, which allows you to operate on the heart while it is beating, and this eliminates the need for the heart-lung machine, and at the same time reduces the risk of complications and speeds up recovery. So again, it helps to both lower cost and improve quality. Similarly, the other innovations that are shown on this chart are contributions that have helped to lower cost and improve the experience for patients, whether they're dealing with cataract surgery, kidney dialysis, or vision problems and problems of the cornea. Finally, the hub and spoke system also allows these hospitals to specialize in rare subspecialties. When you do a lot of surgeries, you find that even rare conditions are being handled quite often, and therefore a doctor can focus or specialize just on the rare conditions and become a worldwide leader in that condition. And so it is the case with Narayana Health and pediatric open heart surgery. This hospital has an 80-bed ICU unit for pediatric open heart surgery patients, which I believe is one of the largest in the world, and they have become world-renowned in this kind of procedure, and they draw patients from all parts of the world, including South Asia, Africa, Middle East, and so on. Let me turn now to the second major area of innovative practice in these hospitals, and that is task shifting. The idea of task shifting is simple. What you're trying to do is carefully match the skill level of the worker or the employee to the task requirements. You make sure, for instance, that doctors only do things that doctors should do, and they don't waste their time on administrative matters, paperwork, or office work. And at the same time, you make sure that nurses and other medical staff do not do anything that is above their pay grade, so to speak, which might be cheaper, but creates the risk that there are complications subsequently. So by matching tasks and skills very carefully, one is able to get the most out of scarce resources, such as the expertise of the doctors. But what these Indian hospitals have done, which is interesting, is to take this idea of task shifting to a whole new level by creating entirely new categories of skills that help to improve the productivity of all scarce experts in the hospital system. Let me illustrate this with the example of Arvind Eye Care, which has for many years now adopted the practice of taking village girls right after high school, putting them through a 2-year training program, allowing them to take on work in the hospitals all the way from admitting patients, maintaining medical records, counseling patients, and even helping doctors in surgery. Today, these kinds of employees, these mid-level ophthalmic paramedicals, as they're called, account for 2/3 of Arvind's workforce, and they are everywhere when you go to the hospital. Similarly, LV Prasad has created a new category of worker called the vision technician, who does the work of optometrist, but who's not really an optometrist. And this person is again provided 2 years of training and is able to conduct basic tests of the eye. And in cases where more complicated conditions exist, the vision technician refers the patient to a real optometrist. The other interesting thing in the LV Prasad case is that the vision technicians are given the option to go to school and become optometrists, because LV Prasad has its own school of optometry. The advantage of this arrangement, again, is that optometrists are reluctant to go and work in small towns and in the villages of India, but the vision technicians are from small towns and villages, and they're happy to have the opportunity to learn some new skills and open up a career path that may take them all the way to, in some cases, a PhD in this field, as 2 people have done through LV Prasad over time. So the effect of this kind of task shifting is to really improve the productivity of doctors. Now, studies have shown that it's not only important when you look at surgeons to look at how long they take to perform surgery, but also to see how long it takes them to shift from one surgery to the next one, or what is known as the wheels out to wheels in time. And the presence of a large number of paramedical staff helps doctors to move briskly from one surgery to the next. And this is illustrated beautifully by the example of Arvind. I know this picture is not very clear. It's taken through a window. And you can see in that room, in the operating room, there are actually 2 doctors working with 4 sets of patients. Each doctor is working with 2 sets of patients. Each doctor is assisted by 4 nurses, or 4 paramedical nurses of the kind that I described earlier. And let me just go back to that picture for a minute. Yeah. And what you can see is that the doctor stands between the 2 patients and has a swiveling microscope that can be switched from one patient to the next. And while the doctor is working on one patient, assisted by 1 nurse, actually assisted by 2 nurses, the other patient is taken out of the operating room. Another patient is brought in and readied so that as soon as the doctor finishes the surgery, he or she can swivel the microscope over and operate on the next patient. So in this manner, in a morning, a 6-hour shift, a surgeon at Arvind can perform 20 to 25 cataract operations compared to perhaps 4 to 5 elsewhere. So the principle of task shifting here is that if you want to get the most out of the doctors, surround them with support staff. In fact, at Arvind, there are 10 support staff for every doctor, and that allows you to get the highest productivity out of the doctors. Finally, another example of task shifting in many of these hospitals is encouraging self-service by patients and their families. It's kind of an extreme form of task shifting, where you just shift the task over to the patient or the patient's own family. Again, sometimes this can lead not only to lower cost, but actually to higher quality. Patients are preferred to be looked after by family members. They may prefer food cooked at home or cooked in a common kitchen in the hospital rather than to have food served by a canteen. And in one example of Narayana Health, they require every patient who's going for open heart surgery to bring 2 family members who have to go through a 4-hour training program on how to care for this patient after the person has gone through surgery. And when the patient comes out of the ICU into the ward, the family members have to take care of the patient in the hospital. Now, the advantage of this is not only that it lowers cost, but the most important advantage is family members learn how to take care of their patient so that when the patient goes home, they know how to care for the patient. This is very important in the Indian context, particularly because when family members don't take proper care of the patients when they go home, you end up with high readmission rates. And so this approach actually saves money and reduces and improves quality at the same time. The last kind of innovation is frugality. Now, frugality sounds like a very simple idea. It is, in fact, very simple. A lot of it is just old-fashioned, cost-saving, penny-pinching strategies. But these hospitals take it, again, to a new level and in a very creative manner and very aggressive manner apply it in all areas. The motivation here, and this is really important to understand what drives the frugality, the motivation here for these hospitals is to maximize the number of patients served. They're not looking to maximize procedures. They're looking to maximize the number of patients served. So any resources that are saved allow them to extend healthcare to more people and to more patients. As part of frugality, these hospitals are very careful about choosing the equipment for their hospitals. If they can do with a 2-color or a 3-color, if they can do with a 3-parameter monitor, they'll go for that in place of a 5-parameter monitor. If a monochrome monitor will do, they'll go for that instead of the more expensive color monitors. So in every area, they look at the value of the equipment and try to be frugal and very cost-conscious in what they buy. They also take very good care of the equipment and try to extend its life. Dr. Shetty of Narayana Health likes to ask that if we can fly a jumbo jet for 30 years, why is it that we have to junk an MRI machine after 7 years? Why can't we maintain it the way a jumbo jet would be maintained and extend its life longer? And doing that may, in fact, allow you to move some of the equipment from the hubs to the spokes after they have run through their normal life and perhaps an improved version of the product is available. You might put that in the hub and move the older model to the spoke. Now, again, this allows you to provide quality care in ways that were not possible before without raising costs. The hospitals avoid waste in every area of their activities. There's one hospital noticed that when surgeons were performing surgery, they were wasting about 1/3 of every suture packet. So they went to their supplier and said, you know what, why don't you make the suture shorter by 1/3 and drop the price by 1/3? And so that's what they do now. Another thing many of these hospitals do is to reuse their supplies and do it in a very safe manner. For instance, in open heart and beating heart surgery, you need to use a clamp. This clamp costs about $160. In the U.S., we would use it once and then throw it away. In fact, the suppliers of the clamp recommend that their product be used only once and not reused. But in these Indian hospitals, they sterilize the clamp and reuse them 50 to 60 times. And they believe it's perfectly safe to do so. In fact, the Joint Commission International, which has accredited many of these Indian hospitals, their rules allow supplies like clamps to be reused, provided they are properly sterilized. So there's nothing wrong in doing that, and these hospitals take advantage of that. Another innovation in this area is to substitute expensive imported supplies with local equivalents that often cost a whole lot less. A dramatic example of that is the intraocular lens, which is used for cataract patients. The product, when initially launched in the U.S., cost $200 for a pair of lenses. In this hospital, found a way to bring down the cost of production, and today supplies them for $2 each and exports more than half its production to other parts of the world. Similarly, these hospitals have found ways to make sutures, medicines, stents, catheters, and so on for about a tenth of the price of the imported product. This, again, requires innovation, but it ends up saving money for the hospital and ultimately for the patients. Another thing these hospitals do is to employ their doctors on the hospital's own payroll. I know the situation is different in the U.S. Many doctors don't work for the hospitals, have their private practices, but they may take their patients to a particular hospital. In these hospitals, the more common pattern is to have doctors on the payroll. What this does is helps in optimally scheduling doctor, equipment, and patient. And all these critical elements can be used and scheduled in a very efficient and productive manner, and that helps to bring down the costs as well. In a similar vein, these hospitals offer their patients fixed price packages for standard procedures. The idea here is that people should know what they're going to have to spend. As one doctor told us, many of our patients are scraping together everything they have. They're probably spending a huge part of their regular income. Very often they're dipping into their life savings for treating someone in the hospital. We cannot afford to spring them surprises on them. We cannot afford to have them readmit their patients because they just don't have the money to do procedures over and over again. We've got to get it right every time, and we've got to know exactly how much something is going to cost us. And so they tend to work with fixed price packages. That means there's no need for additional procedures. There's no incentive for doctors to suggest or recommend additional procedures. And the protocols make sure that any essential procedure is not skipped. So it's a nice balance between doing what is required and not doing anything more than what is required. In fact, to keep costs affordable, these hospitals try to avoid unnecessary procedures. Again, one doctor told us, the important thing is not how much you charge for a service, but whether the services you charge for are really necessary. What really inflates cost of healthcare is not just the price of individual services, but the need to carry out or the incentive to carry out a whole lot of unnecessary procedures. And these hospitals are quite careful not to let that happen. Finally, they take this idea of frugality and apply it to their CapEx spending as well. They decorate their lobbies and rooms and wards quite frugally, in contrast, say, to U.S. hospitals, which sometimes look like 7-star hotels. And they minimize the use of non-medical space. They conserve the space and use it for medically required activities, while the offices of the doctors may not be very big, and the hallways may not be very lavish, and the rooms may not be particularly big, but that frees up square footage for things that are absolutely essential. An example of that is this hospital in Mysore, built by Narayana Health. You notice this is a single-storied hospital. Single-storied buildings are cheaper to construct. It also means you don't need elevators, which further cuts costs. This hospital is not air-conditioned except in the operating rooms and the ICU. That saves both CapEx and OpEx, and it also reduces the risk of infection carried through the air conditioning system. This is a tertiary care hospital, in fact, and the cost of this hospital with 300 beds was about $7 million. It's fully equipped with all of the equipment. Some of that equipment is on a pay-per-use basis. That is, the supplier has installed the equipment, will get paid as the equipment is used, and they don't mind doing that because they know the volumes are going to be large, and they will eventually make a good return on their investment. So what you see in these Indian hospitals is that they have taken some of the principles of manufacturing and applied it to healthcare. They don't think of healthcare as a craft where each patient is unique, each doctor is unique, each procedure is unique. That approach is just too costly. It's like trying to make a Rolls Royce for every patient. What we need instead is the Henry Ford approach. Henry Ford was able to reduce the cost of a car by 87% and thereby made it affordable to many more people in the U.S., and he did it without lowering quality. And that is really what these hospitals are doing. They're taking it a step further in some cases, like the Japanese, and following the principles of lean manufacturing. So all that these hospitals have really done is show that the principles of lean manufacturing can be applied to healthcare services, not just for simple procedures such as cataract surgery, but even for complex procedures such as open heart surgery. Now, what does all of this mean for the U.S.? To take that on, I'm going to turn it back to VG. VG, are you there?
Yes, thanks, Ravi. Ravi mentioned three critical secret sauce of the Indian hospital exemplars: hub and spoke, task shifting, and frugality. And I want you to pause for a moment and think about how U.S. hospitals operate. 180 degrees different from these three innovations. Take hub and spoke. In the U.S., we have too many hubs and too few spokes. Actually, U.S. does most number of open heart surgeries, most number of cancer treatments, most number of kidney. But the problem is, can we just go back to the lesson? No, take it back. I'll control it myself. Don't control it for me, please. Keep it on lessons for the U.S. They do the most number of procedures, but what happens is, please keep it back to the lessons for the U.S. But there are too many hubs and too few spokes. If those volume was done by using the hub and spoke, the cost will come dramatically. Similarly, take a look at task shifting. In the U.S., when U.S. hospitals want to reduce costs, what they do is they lay off lower skilled and semi-skilled employees. With the result now, doctors are actually doing dictation, they are doing logistics, they are doing billing, exactly the wrong kind of task shifting. Talk about frugality. Ravi already mentioned, U.S. hospitals look anything but frugal. They look like 7-star hotels. In a recent study in Time magazine, they mentioned the CEO of U.S. hospitals make $5 million. I'm all for capitalism. I'm all for people making money, but that's greed. Anything but frugal. So the question is, how come U.S. hospitals haven't embraced these breakthrough innovations? At one level, we can say the context is different. There are lots of explanations as to why U.S. hospitals don't embrace these. Could be overly tight regulations, fee-for-service compensation, powerful insurance and pharmaceutical lobbies, unions, or medical malpractice lawsuits. But the interesting thing is, despite these constraints, we already see many progressive U.S. hospitals embracing one or more of these innovative practices. As an example, the Seattle-based Virginia Mason Medical Center has applied its own version of the lean Toyota production system to achieve both higher quality and lower costs. CareMore, which is based in California, provides senior citizens with a caring touch from a new category of health workers known as extensivists. This is nothing but task shifting. Thereby, they produce better outcome at a lower cost. Or Illinois-based Cancer Treatment Centers of America has been providing integrated care for cancer patients for many years. The list goes on. But can we do more? The answer is absolutely yes. Why? Because, as we already mentioned, U.S. does most volumes in categories like heart surgeries and cancer and so on and so forth. Therefore, they can exploit economies of scale. And on top of that, there is already pressure, and that pressure is only going to considerably increase in the U.S. in the future to expand access, improve quality, and lower cost, given the aging population and given so many patients are going to come into the healthcare system during Obamacare. This is a great opportunity for the American healthcare system to begin to really look at healthcare delivery as a vehicle to provide world-class quality at a reasonable cost. Therefore, we believe more U.S. hospitals can and should adopt breakthrough delivery innovations. Now, let's pause for a moment and think what happens if U.S. hospitals don't do it. I and Ravi have a concept called reverse innovation, which says if we don't do it in the U.S., it's quite possible entrepreneurial ventures in India and other parts of the world could actually bring their business models to the U.S. and disrupt the U.S. industries. This is not an academic exercise in healthcare. Actually, just as we are talking, the Narayana Health that Ravi spoke about, can we go back, please? Let me control it, please. Narayana Health. Can we go back to the previous picture? Narayana Health that Ravi talked about is opening a 300-bed cardiac facility in Cayman Islands. Actually, the opening of it is in February 25th, 2 weeks from today. And as you know, Cayman Islands is a 60-minute flight from Miami. And this facility, which ultimately will become a 2,000-bed facility in the next decade, is targeted at American patients. And they want to demonstrate how we can offer world-class quality open heart surgery at a fraction of the cost that it takes to do it in the U.S. But Ravi and I are interested more than the U.S. This is really a global problem. If you take a look at the world today, there are 7 billion people. Out of the 7 billion people, only 2 billion really have access to good quality healthcare. 5 billion do not have that access. And we believe we need to bring world-class quality healthcare to each and every one of those 5 billion. In fact, the world view used to be poverty leads to illness, because poor people, they contract infectious diseases, and that is how they become ill. We have done a good enough job in controlling infectious diseases. We have not eliminated it, but tuberculosis, cholera, malaria, we have done a reasonably good job. What the world today is facing is what we call non-communicable diseases, the lifestyle diseases, diabetes, heart problem, cancer, kidney. Therefore, the new view is illness leads to poverty. Even if you're a middle-class person in India, you get a heart attack. Because it is so expensive, you essentially become poor. Let us just close with this thought. Both Ravi and I feel income inequality is the #1 problem in the world today. And one of the main reasons why there is income inequality is the poor do not have access to good quality health care. When you don't have access to good quality health care, your productive time goes down. Therefore, your productivity goes down or your income goes down, you remain poor forever. I think the healthcare industry has a unique opportunity to deliver world-class quality healthcare at a reasonable cost to every human being, thereby close the income gap. Reducing income inequality has to be the highest form of human achievement, and that is the opportunity healthcare industry has. Thank you very much, and we'll take questions.
Thank you, Vijay, and thank you, Ravi. That was an excellent overview of the work that you've done over the last couple of years. We've got a ton of questions, and we're only going to be able to get to some of them. But you, in your last comments, Vijay, talked about the context being different, and a lot of the questions went to that point. But why don't we just start with a comment Ravi made, which is that, well, look, not all Indian hospitals are performing at the level of the exemplars that you are talking about. So there, the context is the same. So I would love to know what makes it hard within India for some of the excellence you've described to spread.
Well, we think there is as much value in this research for other Indian hospitals as there is for hospitals in other parts of the world. You can always ask in any context why some organizations are more innovative than others. It has something to do with the leadership of these hospitals. It has something to do with the context and the purpose that they have set for themselves. All we're saying is they have shown the way, and if other hospitals, even in India, would adopt these practices, and surely other Indian hospitals cannot give the excuse that they can't do what these hospitals do. I mean, hospitals in the U.S. might say that, but surely hospitals in India couldn't say that. And we hope that other Indian hospitals will pick up and adopt some of these practices. Let me quickly add that although we focused on a few Indian hospitals in our work, we're not saying that these are the only Indian hospitals that practice some of these innovative practices. We don't claim to have looked at every single Indian hospital that has been this innovative, but we do think the lessons of these hospitals are transferable to other Indian hospitals.
Great. Have these Indian hospitals been using, I guess this is a question relating to task shifting, do they use clinical decision support systems in the hands of the lower cost clinicians to kind of have a healthcare force multiplier effect?
Yes, let me respond to that. This is Ravi here. Vijay, please jump in. India is a leading center for software development, and some of these hospitals are located in Bangalore. So it's only not natural that they would look for ways to use technology, including software, to enhance the productivity of their scarce doctors. So Narayana Health has been working on what we call technomedicine, not telemedicine, but technomedicine, that is using technology to enhance the efficiency and effectiveness of their staff. So, for instance, while they used to have the information for their ICU patients, on charts and so on next to the patient's bed, they now have it on an iPad, and all the information is then can be centrally processed, and the system alerts the staff when a patient's condition has gone to something that's abnormal. And beyond this kind of simple application, NH is trying to see if they can develop an expert system that clinicians can use to do the diagnosis of patients. They believe that a good, well-designed expert system can actually be more reliable than just a doctor. And they argue that if a plane can be flown safely from point A to point B on autopilot, surely a lot of the work that physicians do and clinicians do can also be automated in a very reliable way.
Vijay, do you want to jump in on that, just because it seems like what we're describing there is the potential for a leapfrog. People like to talk about leapfrogging by emerging economies where maybe there's some innovation that can happen there that can't happen within our context. Do you think that's true?
Absolutely. I think as Ravi pointed out, I think the internet is going to change India the way automobiles changed America 100 years ago. And the internet is going to change India in every respect, including healthcare, because I think healthcare is going to be fundamentally transformed, and therefore there are going to be quite imaginative solutions coming from not just India, any poor country which has leapfrogged into mobile platforms and has got tremendous cell phone penetration, and therefore I definitely believe healthcare is ripe for that.
A couple questions here that are kind of details of the Indian system. One is, in the U.S. we have this problem of so few doctors want to go into family practice and be general practitioners because it's not as lucrative as being a specialist. So is that also an issue in India?
I think India has a shortage of every kind of doctor and every kind of medical staff that you can think of. I don't think the problem is more acute in that sense. We have a lot of hospitals that produce doctors. The quality of the education is sometimes questionable, and many of them do go into family practice. So I don't think you have the same kind of challenge that you see in the U.S. In the Indian context, specialists are really in short supply. I think I heard that in all of India there may be 100 nephrologists. Somebody was telling me the other day, in all of Indonesia there may be 3 cardiologists. I don't know if this is true or not, but it tells you that specialists and super specialists are really much more in shorter supply in countries like India.
At the hospitals that you were describing, does everyone pay the same rate, or do poor people pay less for, say, a cataract surgery than a rich person does?
Yeah, the hospitals tend to have sliding scales. Some of them will actually charge you according to ability to pay. In some hospitals, they actually have 2 different places to register. Those who don't want to pay or cannot pay go register in one place, and those who have the capacity to pay go register in a different place. Then the back end is the same for both sets of patients. They don't police this. They take you on your word. They believe that maybe 10% of the people who could pay go into the non-paying line, but most of the time, those who can pay, and those who can't, don't pay. The hospitals also have relationships with foundations and charitable organizations that might be able to help some patients. In general, the policies of most of these hospitals is that no one will be turned away because they cannot pay.
What about malpractice? How is that handled in India?
Malpractice is not as big a problem as it is in the U.S. And so that does make a big difference, I think, in the U.S. context. But it would be a mistake, we think, to assume that the high costs in the U.S. are only the result of malpractice. Yes, that is a problem. Malpractice suits and the awards that are sometimes very high does lead doctors to defensive medicine, to practice defensive medicine, but it's not the only reason why costs are high.
Okay. There are lots of other good questions. I wish we could get to them, but I'm afraid we're out of time. So I'm going to end there. I would like to thank V.G. Govindarajan and Ravi Ramamurthy for their insights today, and also thank you to the audience for joining us, and thank you, Siemens, for making this discussion possible. And this concludes our presentation. Have a great day.